Good afternoon, it's good to see you here. Welcome to the 36th Anderson Sport Performance Lecture. Mr. Jamie Reed is Senior Director of Medical Operations for the Texas Rangers Major League Baseball Club, which is an appointment effective as of 2014. Mr. Reed's previous position was one of the head certified athletic trainer and medical director of the Rangers from 2002 to 2013. Mr. Jamie Reed graduated from East Carolina University in 1982 with a Bachelor of Science degree in Community Health and Sports Medicine. Jamie's initial position was one with the Baltimore Orioles MLB club in 1982 as an athletic trainer for their minor league teams. Mr. Reed also served in numerous other positions during that time period, including the Assistant Certified Athletic Trainer at the United States Naval Academy in football and basketball from 82 to 85, and the Venezuelan Winter Baseball League in Caracas in 1986. In 97, Jamie was named as the head certified athletic trainer for the Tampa Bay Rays of MLB, a position he held in until 2002 when he joined the Rangers. Jamie was honored with the Dr. James R. Andrews Excellence in Baseball Medicine Award in 2005, the National Athletic Training Association Most Distinguished Certified Athletic Trainer Award in 2012, and the Major League Baseball Athletic Trainers of the Year Award in 2005, in addition to the Red Romo Athletic Trainer Internship with the U.S. Naval Academy. Jamie was the president of Baseball Athletic Trainers, or PBATS, from 2002 to 2007. In 2013, he was awarded the PBATS President's Distinguished Service Award. Jamie has been married for 30 years, has 3 married children, and 1 grandson, James. Jamie enjoys numerous outdoor activities such as running, half marathons, hiking, snow skiing, winter sports, and fishing. The title of this presentation is Managing the Health of MLB Pitching and the Business Behind It. Please join me in welcoming Mr. Jamie Reed as our 36th Anderson Sport Performance Lecturer.
Thank you very much. It's a pleasure to be here. It's a pleasure also to not see head athletic trainer next to my title anymore. I changed my title right after the season this year. It's something we've actually been talking about for a couple of years, but I spent the last 32 years in professional baseball, which means I spent the last 32 years living out of a suitcase, and it was finally time to be home a little bit more and kind of change my role. So while I'll still be around the Major League Club, I'm also going to be very involved with the minor leagues, just kind of maintaining a medical standard of excellence down there, real involved in player acquirement. So I'll been very involved with the free agent industry this past 2 or 3 months, and as you know, we've signed a couple free agents, and also real involved with the medical aspect of the amateur draft, which I'm assuming a lot of you guys would like to have your name pop up there in next May or June. So kind of fun and kind of nice to be home for dinner a little bit more than I have been the last 32 years. But I'm excited to do this, and I appreciate the invitation from Barry and the department. I was telling him earlier, I went to East Carolina. At the time, the NATA was actually headquartered, which is our governing body, across the street from East Carolina in Greenville. So it had a really good program. But kind of the one class that made everything kind of click was kinesiology. I had a professor there named Dr. Ray Martinez, who was a huge baseball fan. And he taught the mechanics, the whole semester was taught the mechanics of Pete Rose hitting and Jim Palmer pitching. I was a huge Baltimore Oriole fan growing up, so that helped. But it also helped me kind of transition to the sports medicine side of it, understanding the mechanics and the stresses. And I was learning the anatomy, and I kind of put the two together, and that's kind of where my career went. Today we're going to talk a little bit about baseball and my role, and now Kevin Harmon, new head athletic trainer with the Rangers, his role in kind of preserving pitching, because really pitching is the premium position in baseball. We have 3 athletic trainers who work out of our athletic training room, and I'm going to say training room a lot because that's old school, and I'm still kind of old school. But out of the training room, we have 25-man roster, 12 or 13 pitchers, so roughly 50% of our roster is pitchers, but probably 85% of our time in the training room is devoted to pitchers, keeping them on the field. It's the hardest thing we do in baseball. So we're going to talk about that a little bit. So if we talk about the premium of pitching and understand it, it probably starts right here. And I can get this out of the way. You see Cindy okay? I'll walk around, it's better. There's a lot of money being paid to Major League pitching. A whole bunch. $1.3 billion last year to a very, very small finite number. 12 pitchers times 30 clubs. That's a whole bunch of money guaranteed to a whole bunch of guys who can throw a ball over the plate. They can throw it hard, they can change speeds, they can make it move a couple of different directions. But that onus, that responsibility falls back on the medical department to keep those guys out there. Premium pitching, amateur draft last year, the best high school players in the country, the best junior college players in the country, and the best juniors and seniors in a 4-year program like these guys are, the very best. We have 9 positions to fill, in the American League actually 10 with a DH. 28 of the first 50 picks were pitching. So pitching is an absolute premium in Major League Baseball. I know John Daniels spoke here on this very stage a couple years ago, and when he talked about it, he talked about building a baseline. The foundation was young, developable starting pitching, because you can't afford to go out and buy it. And we'll talk about that a little bit later. But really, my job, the medical job, and Jose Vasquez, our strength and conditioning coach, job is to keep those guys out on the field. Today's athletes are bigger, stronger than they were certainly when I started 30 years ago. This is, as you probably know, is one of our starters, Matt Harrison. He's 6'5", 260, and he's probably a little bit big, but not a whole lot bigger than the average size Major League Baseball pitcher now. It's become a big man's game. These guys used to play basketball or football, now they're playing baseball. But bigger and stronger means bigger and more powerful forces on the body, forces that want to kind of tear the body apart. So our job is to try to keep these guys out there. And it's pretty lofty goals if you think about it. When John Daniels signs pitching, when we develop through the minor league system, the goal is to get these guys to the big leagues. And the goal is, if you think about it, 200 innings, that's a lot of innings. 3,500 pitches is the one number that always jumps out to me, because these are 3,500 quality, 100% intensity pitches to get Major League pitching out. So that's a lot of pitches, and this is just in one season. 30 to 35 starts, 35 bullpens, and that doesn't include spring training. I leave a week from today for Arizona. Spring training is 45 days. We have 1 day off. Pitchers pick up the ball every single day. They're throwing bullpens every other day. They're throwing in games every 3rd, then 4th, and 5th game as they get stretched out. So these guys are absolutely getting worn down for an absolute marathon of a season. So those are big goals, big, big goals. And now you understand what our problem is. Because in most sports, an injury is like a lightning bolt. They're healthy bodies, they're athletes out there running around on the field, and then it's contact with an opponent, it's contact with field, bad cut, knee, ankle, hip, low back, whatever it is. Baseball is totally different. Totally different. I deal with impact injuries, and I run out on the field when guys get hit by a pitch, or they have a collision breaking up a double play, or they run into the wall. But most of what we're dealing with is pitching, and that's erosion. Erosion of the rotator cuff and erosion of the ulnar collateral ligament in the elbow. And so you look at that and you try to predict how long is that going to last. John Daniels comes to me and take a look at these MRIs, look at the injury reports. Is this guy going to last one more storm, one more year, or you think we get 5 years and a $55 million contract out of him? Anybody want to predict how long that tree is going to stay? You can't. You really can't. That's the hard thing about my job in baseball. Understand that 90% of injuries in baseball are overuse. Overuse, right? Constantly cocking your arm and throwing the ball. Predominance is shoulder and elbows. I probably spend 90% of my day working on shoulders and elbows. That's the ACL of basketballs, it's the chronic knees of basketballs, it's the ankles of other sports. But here's some, if they're take-home points, these are the 2 of them. For pitchers in minor league baseball, so they've already signed a pro contract, if they have surgery to their elbow, they decrease their chances of going to the big leagues by 50%. And recognize that the biggest surgery you can do with an elbow is an ulnar collateral reconstruction, Tommy John surgery. And that's where you take a tendon and weave it back into the elbow to strengthen up the joint. Right now, we're getting about 87% of those guys back to Major League Baseball, back to the previous level. So even with 87% of Tommy Johns coming back, it still decreases your chances after surgery of the elbow by 50% of making it. But here's the take-home sign, and this is where I make and probably lose my money and a lot of the club's money. If you have surgery when you're in professional baseball on your shoulder, you decreased your chances of making it by 75%. 75%. So on average, about 15-18% of kids who are drafted go through the minor league system, play in the big leagues, subtract 75% of that number. That's your chances of making it to the big leagues after shoulder surgery. So we do everything we possibly can to avoid shoulder surgery in our industry. There's been a bunch of research by Dr. Mike Sakati, who takes care of the Phillies in Philadelphia. Neil Elitrash, he's from the Curl and Joe Clinic in LA, which is one of the foremost sports medicine baseball clinics in the country. He takes care of the Dodgers. ASMI, the American Sports Medicine Institute, which is Dr. James Andrews, is probably the biggest name in sports medicine in this country. His institute, National Institute of Health, and even Sutton Med, which is our internal Major League Baseball medical reporting system. We've done a bunch of research, inconclusive studies, but what's it say? It says that probably 8 to 14% of guys who have shoulder surgery come back to their previous level. 8 to 14%. I sat with Dr. Andrews last week, I spoke at his conference last weekend, and he said it's probably closer to 4 or 5%. Now, everyone's got a different grading standard, okay? Everyone's got a different grading standard. But mine is based off the guy I answer to, John Daniels. Because if he signs a pitcher for 5 years for $50 million and he has surgery in his first year or second year, until he's that pitcher that he signed for 5 years for $50 million, it's a failure. If he threw 92 to 95 miles an hour and he comes back from surgery and feels great, but he's throwing 87 to 89 miles an hour, it's a failure. He's not the same pitcher. That's why we avoid surgery of the shoulder at absolutely all costs. And Dr. Andrews, who I mentioned, he's based out of Birmingham and Pensacola, Florida. He's probably the premium doctor in all of baseball now, in the NFL too. I used one of his quotes that was in ESPN The Magazine last fall, and he said, the last thing you want to do is have your shoulder operated on, and that's the truth. You think about knees, think about how many guys in the NFL have ACLs, medial meniscus, some lateral meniscus, and they come back and play the second half of the season, the same guy they were before. Not the case with shoulders. So this is the place I least want to go, and that's the mound during a game, because I'm worried about pitching. And when I'm out there, and I'm out there with Wash, I look very concerned because I hate being out there. Our pitching coach is on the other side, and the umpire is making sure that we're not talking baseball strategies, but truly talking about health issues. We got to see if this guy is okay to continue to get major league hitters out. But I have to look introspectively and think, did I miss something in the last 5 days since his last game? Was he sore? Did he have bad range of motion? Did he lose anything? Were his exercises good? How was his bullpen? Did I miss something to send a guy out there injured and maybe injure himself worse? And there's also a huge ripple effect when a starting pitcher comes out of the game. This guy comes out, if Derek Holland comes out of the game in the first or second inning, that means the bullpen has to pitch 8 or 9 innings. You know what that means? That means the next day, those two guys who each threw 4 or 5 innings are going back to the minor leagues because we need fresh arms in the bullpen the next day. So that's 2 player moves. He's coming out of the game, he's going on the DL because he's not going to make his next start in 5 days. Now we have to go get another pitcher from AAA or AA. So there are 4 player moves by me being out on the mound saying this guy can't go anymore. And that's not good, and that's even worse when John Daniels calls you on your ride home. So that's what I'm trying to avoid. I don't know how many of you have seen rotator cuffs, but if you think about the posterior rotator cuff, it sits on the back of your scapula, on the back of your shoulder blade, and it's essentially 3 muscles about the size of your 3 fingers, okay? And they sit on your back shoulder blade. If you feel the soft tissue on your shoulder blade, your scapula, that's your posterior rotator cuff, and they wrap around to the front. Well, this is kind of the money shot for MRIs, for doctors to look at, orthopedic surgeons to look at. And essentially, if you took your shoulder and put it through a bread slicer and you went front to back, this is the rotator cuff. And do I have a pointer here? Maybe not. Maybe so. That's the rotator cuff, and this is where it sits right here. That's called the foot. It's on the humeral head, the little plateau. And that's where the rotator cuff, so it's going to the back of the shoulder blade there, comes through that little notch, and that's where it sits. Well, this is a shoulder rotator cuff, and you can see it's about 50%, the foot is pulled off, and that's probably about a 75% interstitial tear through the rotator cuff. That's probably a career that's not going to last a whole lot longer. That's not what we want to see. But it's critical to know that the MRI is a tool. It's not a predictor. And I'll give you an example. I took 2 guys when I was head athletic trainer with Tampa Bay. Dr. Andrews was our medical director. And I took 2 free agent pitchers up to Birmingham, and we had MRIs of shoulder and elbow and a physical by Dr. Andrews. One guy had less than 10% change in his rotator cuff. The other guy had 60% tear of his rotator cuff. Pretty easy prediction, right? The guy with less than 10% is going to pitch a long time, give him a 5-year deal. The other guy, 1 year and maybe an option. That's the business side. Well, the guy with less than 10% pitched 1 2/3 innings the rest of the year and the rest of his career. Complained of shoulder pain the rest of his career. The guy who had a 60% tear of his rotator cuff pitched 200 innings and 200 innings each of the next 5 years. So it's not a predictor. It's not a crystal ball. It's a tool, but it's not the absolute answer. So you can see, when I'm dealing with pitching and trying to keep pitching in and on the field, I'm surfing with sharks. Waves are great, could be an awesome ride, but one time it's going to get me. And when it gets me, it's all over. It's not fun. When I first put this talk together, and I gave it at the winter meetings, a similar talk to the doctors, team physicians, I asked three people I respect very much in the game, and unfortunately Lou Yoakum, who took care of the Angels, and was at the Curl and Joe for a lot of years. We lost him to cancer this spring. Wonderful doctor, and probably operated more Tommy Johns than anyone else in the history of the game. I asked Lou, I said, Lou, if there's one exercise that a pitcher could do to protect his shoulder, short of doing shoulder work, what would it be? And he didn't hesitate. Core. It's all about the core. The stronger the core is, takes all the stress off the shoulder, do core. I don't have to tell you who this guy is because you all go to school in Texas, but when Nolan Ryan was our president up until a couple months ago, an unbelievable Hall of Fame career, longevity that probably would never be matched again, I asked Nolan, I said, Nolan, what's the one exercise pitchers should do to protect their shoulder? And he didn't hesitate. Squats. It's all about leg strength. It's explosion down the mound, under control. Squats. Then I asked Dr. Keith Meister. Keith is our head team physician, the best team physician I've worked with in my 32 years, and he's right down the street at MCA Hospital, takes care of the Rangers. And I asked Keith the same question. I said, what do you think, what's the key to keeping pitchers on the mound? And he said, the key is they start their career healthy. Start their career healthy. And that's followed up by this. 40% of players drafted, right? So the best high school and college kids, 40% of them drafted are out of baseball in 4 years. But when I go through all the medicals on all the kids who are going to get drafted, we flag some of them. Some get a yellow flag, some get a red flag. If you got flagged, 75% of those guys are either out of the game or have surgery within 2 years. And we already talked what surgery does to your chances of making it. Almost destroys it. So Keith Meister may have something. You need to start your career healthy. So when I came over here in 2002, I was charged with the responsibility of uplifting the medical department for the Texas Rangers. So we took a step back and we decided to make consistency across the organization. Consistently shoulder and elbow programs. From the kids who sign and go to Spokane, Washington in the summer to the major league guys, everybody's doing the same program all the way through. We're going to do long toss pretty much the same way. We're going to try to be consistent in that, and we're going to do our conditioning. We brought in some really qualified strength and conditioning specialists, coaches, to run our program. And I hired Jose Vasquez 2 years later. Jose is a physical therapist by training who is also a strength and conditioning specialist. And we kind of raised our standard. But you can imagine, you guys can really imagine, you get signed, you go to Spokane, and then you go to Myrtle Beach, and you go to Frisco, and the stadium is getting a little bigger. You go to Round Rock, our AAA team, stadium is getting a little bigger. You walk into our stadium, it's got 3 decks, the lights are brighter, the TV cameras all over the place. You can feel the pressure. Well, the one thing I want to do is make it comfortable for everybody, so everything stays the same. When you walk into the training room of the Texas Rangers, we're doing the same program that they're doing down in Myrtle Beach and in Spokane and around Rock. Everything's the same, so there's a comfort level. We do a lot of range of motion checks. It's one of the things you need to understand with shoulders is everyone has this kind of window of shoulder motion, internal and external rotation. But with most pitchers, and we've done a study, got a couple studies with CT scans, most pitchers have more external rotation than internal rotation. And actually, I did a lot of throwing when I was young, and I used to do all the throwing programs with the Orioles. You can see I have a lot more external rotation at the cost of internal rotation. That's a normal throwing shoulder. It's just rock back. And the analogy I would use is long runway, right? This is the acceleration. This allows guys to throw 90 miles an hour. So they got a really long runway to take off that Learjet. But at the cost of, they got to land that Learjet on an aircraft carrier. And that's where the rotator cuff does it. A lot of its work is after ball release. So we're constantly checking our guys who are losing internal rotation. We're constantly working internal rotation. When I started my career, we were always working external rotation. Then we learned, no, we're going the wrong way. We got to go this way. So we're constantly staying on top of these guys. And then it's also really, really important that I know my player's history. If I know that around the All-Star break, this pitcher we just signed has had internal impingement, rotator cuff inflammation every year, I got to start looking for it in May and June. I got to know his history, and we got to need to cut that off. Because a guy who leaves a game with rotator cuff pain is probably not going to pitch again in the big leagues for at least 30 days. Because he's got to get healthy, he's got to get strong, and then he's got to go back to the minor leagues and sharpen his game. So I need to stay on top of these guys, and the best way to do it is to know everyone's medical history. So our strength and range of motion is consistent throughout. That's Kevin Harmon over there, who just replaced me as the head trainer, athletic trainer, sorry, Cindy. And he's working on internal rotation. And these are little cuff weights. I mean, our guys, and you guys know, they throw all kind of iron around in the weight room. Rotator cuff, 3, 4, 5 pounds is probably all you need. That's all it is. And again, we're talking about 3 little muscles the size of your fingers. We have a beautiful weight room, and that was something Nolan Ryan did for us. We tripled the size of our weight room, opened the ceilings, have every piece of equipment possible in there. But that's all about explosive, accelerating the balls. We have a little corner in the athletic training room, and this is really where we do all the shoulder work. You know, cuff weights, tubing, rebounders, and we do a lot of it on the physio ball, so we activate the core while we're doing rotator cuff stuff. So we have work days and rest days. We give guys options. Some of them like to do plies, rhythmic stabs. Matt Lucero, who's our other assistant athletic trainer with us in the major league level, loves to use the Jaeger bands. He brought those in a couple years ago. I'm not a huge fan of the body blades. Some pitchers love it. I usually don't throw guys on it, but that's another way to do it. And we got to think about scapular stabilizers. What are those? That's the rhomboids, the serratus, and the lower trap. And you think about your shoulder blade, it protracts and retracts. It retracts when you set your arm for cocking, and it protracts when you decelerate the ball. So those are muscles that kind of keep the scapula firing in the right pattern, the right synchrony. So we got to work those things. But probably the most invaluable feedback I get is when I do manual therapy. And it's manual soft tissue before they throw, and I love to do manual exercises afterwards. And I will tell you at 54, I'm not looking forward to the next 3 weeks when I have 30 pitchers in camp, and I'm doing this about 15 times in 2 hours. Because these are big, strong guys, and they throw me around now. But this is the feedback that I can't get from anywhere else. This tells me if a guy, how his range of motion is he pain-free all the way through, what's his strength, what's his deficits, does he have fatigue, does he have weakness? And this is where I can kind of cut a problem off at the pass. So it's a lot of work. It's a lot easier to send a guy over in the corner and say, do 15 sets of tubing. I'd rather do the manual stuff. It's interesting, Dr. Bob Watkins, who's kind of the father of sports spine surgery and rehab out of LA, gave us a lecture about probably in the late 80s in professional baseball, and he was talking about the core program, and none of us had really studied the core when I was going through school. So we all learned how to do the physio ball exercises, the dead bugs, and we all got our pitchers on it and our position players on it. And we were doing kind of rotational stuff, but it was pretty static, wasn't real dynamic. And we noticed in the mid-90s we had this unbelievable rash of oblique strains. And I had GMs, multiple GMs come up to me and said, I've never even heard of oblique. I don't know where the oblique is. And I've got guys missing 4 weeks on the DL because they strained the oblique. Where did they come from? What we realized is we were doing a whole bunch of core stuff, but it's kind of isometric, slow moving. That's not what hitters do, and that's not what pitchers do. They do dynamic, fast twitch stuff. This is how we train the core now. We do it hard and we do it fast because we have to prepare these guys to swing the bat and throw the ball. I throw this picture in here because if you think about a weight room, you guys think about all the exercises you do, all the exercises that a pitcher does, most of them are to explosion. It's an explosive force down the mound because they want to throw 95 miles an hour because that's where the money is. But all the work we're doing in the athletic training room is pretty much from ball release afterwards. So we're trying to slow the arm down when they've done all these explosive exercises to speed the body up. That's the problem we run into. Talk a lot about long toss programs. There was a time in my career, probably 10 or 15 years ago, where I thought a guy who makes his living at 60 feet 6 inches, 120 feet is long toss. So we shortened everybody up. There have been a bunch of studies out of ASMI, Glenn Fleisig, and showed that the mechanics and stresses don't really change as we lengthen the guys out. And Nolan Ryan kind of took our cuffs off and said, you guys do whatever you want. Let the pitchers throw what they want to throw. And what we found is long toss, 150, 200, 250 feet, is a great exercise. It's a great way to speed up your arm. It's probably the best way to speed up your arm. And it's safe. But you notice I've got guys doing long toss pregame. Some guys are long tossing at 90, 100 feet, and some guys are getting ready to stretch out to 150. So it's a very personal thing. Colby Lewis, God love him, he's just coming off a hip resurfacing. For him, 90 feet was long toss because he couldn't get it going with his hip. Alexi Ogando probably throws 250, 275 3 times a week. And it's an exercise, but it's an arm strength too for speed. So it's a very, very personal thing, and we don't really put the cuffs on anybody. And if you study kinesiology, and if you study exercise, and you study ways to keep guys healthy, you understand eccentric and concentric, right? So bicep, if I'm concentrically working it, I'm shortening the muscle, right? But if I pick up a 10-pound weight and slowly let it down, again, I'm working the bicep, but I'm allowing it to get longer as I control it. Well, C.J. Wilson right here, and had very dramatic follow-through. He's got one set of hamstrings working concentrically and another set of hamstrings is working eccentrically. So we have to train accordingly. We can't just go out there and do a bunch of concentric work, which is easy work to do and less painful, and then ask his muscles to work eccentrically. We're setting him up to fail. So we have to understand that in our field. And the same with the rotator cuff. Concentrically, the rotator cuff is shortening right here to set, early cocking phase. But at ball release, it actually is getting longer and slowing the arm down. So we have to work the arm eccentrically and concentrically to prepare it to hold up. This is kind of like the gas tank. This is kind of like the odometer, really. It's on your car. You got the big odometer and you got the trip odometer. So we're constantly looking at the volume of work guys are doing. A week, a month, a season, a career. Trying to control it a little bit. It's really, really important to watch pitch counts, and we do, but again, we've taken that constraint off a little bit, but allow guys to understand that there's so much work, and if the more they pitch, the less we exercise them. And the less they pitch, the more we exercise them, but we're constantly trying to control that volume and understanding it. And I also think this is a neat picture of Dwight Gooden, who I had in Tampa Bay. You see the force that he's creating. He's actually dimpling his olecranon, the skin off the tip of his elbow. You can see that's not normal. But that's what almost all pitchers do. That's the force that's created in internal rotation. And that's what the rotator cuff is going to have to slow that down. So you need to understand the forces these guys are creating is just unbelievable. So what do we do? This is our equipment manager, Hoggy Price. Been around UTA a bunch, you might know him. But it's really, really important when we go through spring training, 45 days long, 1 day off, and then we start the Major League season. We play 161 games in 175 days. And if those 14 days off, we're traveling, so it's not really an off day to the West Coast or the East Coast, probably 5 of those 14 or 15 days. So there's very, very little rest. So it's really important, and young athletes don't like to hear it, but there are days guys come in and say, you're off. You can go ride the bike if you want, and that's it. We have to measure their work, their volume. So we have to, as much as we have to work smart, we very much have to rest smart too. And the other thing we have to do is understand the calendar year for baseball. 2 weeks ago, and I fight this fight every year, but I lose it every year. We had a mini camp, a pitcher's mini camp over at the ballpark. So we bring in the 17 best young arms we have in minor league baseball, and we ask them to get ready to throw this mini camp because our coaches are bored and they need something to do in January. Well, these guys started in December, where all my other major league pitchers are starting in January. So these guys are 2 months ahead of the curve when they start preparing for this mini camp. They come in and throw bullpens for a week, and then they don't throw again bullpen until they go back to spring training 6 weeks from now. And then if they happen to make their major league club, the season's a month longer, and if we happen to go to October, which we're planning on, all of a sudden their season's 4 months longer than the season they had before. It doesn't make sense. So you gotta manage it. You gotta manage, if you tear your ulnar collateral ligament in July and you're going to miss a year, you got to manage those off seasons so you kind of time yourself the year you're going to be healthy and ready to go and you didn't work 18 straight months. Really, really important. This kind of goes back to what Dr. Keith Meister was talking about, starting your career healthy. And it all, for me, starts right here. Little League World Series. And it started a long time ago. And I know we used to watch in fascination when those Taiwanese pitchers would come over and they had a slider and a curveball and a changeup and they overpowered everybody, because they seem to be bigger and who knows where the birth certificates were, but whatever. But anyway, these guys are throwing like 90, 100, 110 pitches as 12-year-olds and dominating. I'm in the major leagues. I got 25, 30-year-old, highly skilled, highly conditioned athletes, and my pitching coach is starting to make them adjustments at 80, 85 pitches. He's starting to get guys moving around in the bullpen. And these guys are going 110 pitches? It doesn't make sense. Well, they stepped in 2007 and lowered the pitch count to 8 times their age. So they can go 84 pitches, and on the 85th pitch, they have to come out of the game. Still way too many for me for a 12-year-old. Way, way too many. And then in 2010, they finally said, all right, if you go 85 pitches, you got to have 4 days off. Before that, they could go back-to-back days. And I've treated many pitchers who played at LSU and a couple other schools, and they were Friday starters and Saturdays long guys and Sundays closers. You know what those guys do? Have short careers in the big leagues because they've torn up their cuff. So this is where the problem really starts. Another guy I really, really am careful about are guys who change roles. And you recognize this big donkey. He was our closer and really, really good one in the World Series for 2 years and had great years. And we decided, he and his compadre, Ogando, we decided to make starters out of because they're big, powerful arms and starting pitchers harder to find. Well, they both broke down. Because basically we've trained these guys as sprinters, 1 inning, shut the door, end the game, and now we've asked them to run marathons, and they break down. So I'm not saying you can't go from one to the other, but as the medical guy, I keep the finger on these guys' pulse really, really big. And for those of you who study mechanics, when the pitching coach talks about throwing uphill, that's what he's doing right there. He's throwing uphill. So mechanically, he's putting a load on his shoulder he doesn't need to. In communication, as the head athletic trainer, I talk to the pitching coach before any pitchers went on the field and especially after pitchers threw their bullpens, because I wanted to know what he saw. I want to hear that they got loose quick, it was coming out of the hand really good, great command, short, crisp workout, and he got out of there. I hate to hear, hey, never really got loose, couldn't really get it going today. This guy's supposed to start a game in 3 days, and he couldn't get it going. So I need to know what he's thinking. At the same time, he needs to know what I'm thinking. I can tell him if the guy's weak, he's sore, I don't like what I'm seeing, and he can kind of tone that bullpen down a little bit, try to save it for a game. This is something I never really thought about growing up in Maryland, being with the Baltimore Orioles, being in Tampa Bay where there was a film stadium until I came here. And it was actually a pitcher we had named Kevin Millwood, and he had a cramp in the middle of a very, very hot Texas game. Guys didn't know it gets hot here in Texas in summertime. And it was a really, really mild hamstring cramp. And he was sore the next day and the next day. So we did a little MRI, and he actually, with that cramp, that really tight contraction, he actually strained the muscle a little bit. He missed 5 weeks because he dehydrated. 5 weeks. We're super aggressive. We actually IV almost all of our pitchers and catchers and some position players before every game. We do 150 to 200 IVs before a game starts. So that we send them out absolutely maxed out. We've had 2 cramps in the last 6 years. Both of them in the same day, both of them in Atlanta, a day game. We haven't had any cramps in Arlington in the last 6 years since we started IVing. It's really important to understand where pain is in a shoulder. Used to always be, guys came in with ball release pain. As soon as I release it, well, that's when the rotator cuff is starting to eccentrically work, and everything else, all the forces to get the ball to this point are big, and now the cuff has to do a whole bunch of work. But we got really, really good with our shoulder programs, and we started seeing less of this and more of this. And this is what we call late cocking pain, internal impingement, where you're actually wringing the rotator cuff out and it actually gets pinched on the backside of the joint. They've got some changes back there. If you ever saw surgery of an arthroscopic surgery of the shoulder of a pitcher, it looks like seaweed kind of blowing through the tide. That's what it looks like. And that tissue actually gets trapped in the back of the joint. So it's important that we recognize mechanically where the pain is so we can treat it. So this internal impingement, I probably see 10 times more than I see ball release pain now. And that's totally different than what we saw 15 or 20 years ago. And I've got a great doctor, Keith Meister, who knows how to take care of this, and usually guys don't miss much time at all. I have to talk a little bit about this, thoracic outlet syndrome. And it's basically where the brachial plexus, which is the big nerve group that runs down your arm, and the subclavian vein or arteries run through the arm. And they basically, right underneath your collarbone, your clavicle, is the first rib. And it goes over top of your first rib and then underneath your clavicle, and God kind of protected it that way. The problem is, it can kind of get held up. And this is kind of like the silent assassin of pitch.